All right, I think we'll just start now. Hopefully you can hear and see myself and the slides. Welcome to today's webinar. I'll be your host today. So my name is Sophia and I'm a partner relations manager at GlycanAge, as well as a glycobiology scientist. And today we will be discussing a very important and timely topic, and that is measures of chronic inflammation. So in recent years, the concept of inflammation and its management has gained significant attention, especially in the field of longevity and prevention, and we are constantly reminded that high levels of inflammation are linked to an increased risk of developing chronic disease. However, the best methods to measure inflammation are not always clear, and while there are several tools available on the market, determining what is the most effective one for you and your patients is crucial, and that is what we will be exploring today. So before we move on to the agenda, I would love if you guys who are practitioners could share in the chat what metrics you're currently using, if any, to assess chronic inflammation. That would be very helpful for me to understand where to focus, what to discuss. So yeah, if you could share this in the chat would be great. And while you do that, I will walk you through today's agenda. So we will be starting by defining inflammation as a concept, and we'll be introducing the parts of the immune system that are responsible for this inflammatory process. We will be delving into the acute inflammatory pathway, which is essential to understand when we are discussing these currently available markers. We will also be touching upon the causes of chronic inflammation and how it relates to age and age-related diseases. Additionally, we will be discussing why chronic inflammation is important in the context of longevity and prevention. And then in the second part of the webinar, we'll be shifting to the actual markers of inflammation currently available on the market. We will be examining signaling molecules, acute phase proteins, blood count, organ-specific markers as well. And the best part, I would say the most intriguing part, are the new generation of inflammatory markers such as suPAR, DNAm, CRP, and glycans. We will also have some time at the end for a Q&A, so please, if there are any questions throughout this webinar, feel free to leave them in the chat. So the aim of this webinar is to help you differentiate between acute and chronic inflammation, to understand the inflammatory response and know where specific biomarkers fit in this process. We want to present currently available biomarkers, and by the end of this webinar, you should be able to choose the right one for your patients. Keep in mind, please, that this webinar was created as a resource for you to be able to come back to any time. So you will see that some of the slides will look quite busy, and I will be walking you through the main points. But what I wanted to say is that we will be sending both the slides and the recording after the webinar. So let's start. So I would say that an overview of the immune system is very important to have when we talk about chronic inflammation and generally measuring inflammation in your patients. And we all know that the immune system has several roles in our body, but its main purpose is to protect us by eliminating foreign or non-cellular material such as bacteria, viruses, fungi, parasites, and also damaged cells. And the immune system is divided into two branches: the immune system, the innate immune system, and the adaptive immune system. So the innate immune system is the first barrier that any pathogen will encounter. This includes our skin as a physical barrier, mucous membranes, and our intestinal lining. So these are physical and chemical barriers that prevent pathogens from entering our body. If a pathogen manages to get in, the innate immune system will trigger an immediate response. Unfortunately, it has limited specificity, meaning that anything resembling a threat will trigger the response because our body wants to be on the safe side. And there's also a limited diversity of responses. So usually this response is very aggressive because the aim is to eliminate the threat right away. The innate immune system also has no memory, which means that the same response will be triggered every time we encounter the same pathogen. On the other side, we have the adaptive immune system, which is a bit more refined and nuanced. So the first response is always the innate immune system, and it takes at least several days to activate the adaptive immune system to catch up and to understand what the actual threat is, and then determine what process needs to be triggered to respond to it. So the adaptive immune system will include our immune cells and especially lymphocytes, so B and T cells, as well as antibodies and other components. It's a response that is only directed to specific antigens that initiate it, making this response more controlled compared to the innate immune system response. So depending on the type of inflammatory agent that it recognizes, it will have a different range of immune responses. Following that, it also has a memory, allowing for a more efficient response upon re-exposure to the same pathogen. So what is acute inflammation? What's inflammation in general? It is a very complex biological response, as you'll see just now, of body tissues to harmful stimuli, such as pathogens and damaged cells or irritants. And acute inflammation is part of our innate immune system. And its purpose is, as we just mentioned, to eliminate the initial cause of injury, to clear out damaged cells and tissues, and also to initiate tissue repair and healing. When we first learn about inflammation, we would usually learn about the 5 very obvious signs of inflammation, and that is swelling, heat, altered function, redness, and pain. You can remember these by the acronym SHARP. And these signs are non-specific, but indicate the presence of acute inflammation. And some examples of acute inflammation would be something that we all encounter, so getting cut by a knife, being bitten by a mosquito, or burning your hand on the stove. And these incidents would exactly come with these symptoms. So they would come with pain, with heat, with redness, swelling, and with loss of function. On the molecular level, the acute inflammatory response can be split into 3 phases. So the first one is inflammation itself, and it is split into recognition and activation, into vascular response, and into cellular response. The second phase is when our body is trying to get the injured part to the way it was before, both in terms of looks and function. So this would include cell proliferation and matrix deposition, and then finally matrix remodeling. So we have the same function as we had before the injury. So as we mentioned, the first step is recognition and activation. And when something happens, like accidentally cutting ourselves with a knife, bacteria can and unfortunately will enter the wound, and then some of our cells are also damaged in the process. And what happens is that both the bacteria and our own cells will release their contents because they've been injured or cut, right? So for bacteria, this would include cellular components such as plasmids, for example, as you can see in this picture. And this is something that is called a pathogen-associated molecular pattern, or PAMP. And if it comes to our cells, if our cells are injured, they will also spill their own contents, such as mitochondria and other cell organelles. And this is something called damage-associated molecular patterns, or DAMPs. So these 2 terms are very, very important in terms of understanding how our immune system works. So please try to remember them. And then what happens is that these molecular patterns will get recognized by PRRs, or pattern recognition receptors, which can be found on our macrophages and our mast cells. So these receptors recognize that something foreign is around them. This is exactly what their purpose is. And then its function is to activate the macrophages and the mast cells. So when the macrophages and mast cells are activated, they start releasing inflammatory molecules. And this response, again, it is not specific, it has no memory, and it's very quickly activated, so it activates within minutes. What these cells secrete is inflammatory mediators such as histamine, serotonin, and cytokines, so interleukin-1, 6, and TNF-alpha, and other mediators that help in promoting this inflammatory response. Now, the next step is the vascular response. And why this is important? It's important because the aim is to dilate the blood vessels to allow other immune cells from the periphery of our body to get to the injury site and to enter it in order to help clean it up. So the key players involved in this step are obviously cytokines, which increase vascular permeability, which is just a very fancy way of saying it allows for more space between endothelial cells within our blood vessel walls. And this will allow the other cells from the periphery to enter the injury site. These endothelial cells are also important because they help in vasodilation, meaning to allow more blood flow and more cells to come to this site of injury. And this is why we see redness and swelling often when we injure ourselves, because this is exactly what's happening. So our blood vessels are dilated and more blood and more cells are coming onto the site. Once we have recruited our immune system cells, so this would be neutrophils for the most part, they will grab onto these endothelial cells. As you can see here, they almost have these hooks. Whenever they sense inflammation, they release these hooks onto which the neutrophils, the immune cells, grab onto, and then they squeeze through the space in between endothelial cells and enter the site of injury in order to help clean it up. So this signaling is very, very important because it helps fine-tune the immune response. However, what is even more important than that is recognizing that the inflammatory response is rapid, but it's also very highly regulated. So once the injury is recognized, pro-inflammatory agents will be secreted to address the threat, right, as we just discussed. But after clearing the site of injury and initiating this rebuilding process, anti-inflammatory agents are needed to balance the response and to prevent prolonged inflammation. And this balance will be critical to prevent excessive tissue damage and also to promote healing. Now, if this doesn't happen, if we are looking at a prolonged inflammatory response, we are actually looking at the slow buildup of chronic inflammation. So let's now discuss the difference between acute and chronic inflammation. So what we've been discussing so far is the acute inflammatory response. It is a response to a real threat. It starts quickly and quickly gets resolved. The symptoms will be usually localized, and it is very easily identified and diagnosed. Now, on the other hand, chronic inflammation can be caused either by an unresolved acute inflammatory response, just as we said right now, or by constant activation by outside factors and lifestyle. And I think this is very important to focus on here, because chronic inflammation doesn't always have to follow acute inflammation. It can also happen or accumulate by itself without necessarily having the acute inflammatory response first. Chronic inflammation can last from a couple of weeks or even up to years and decades if it's not addressed. It's usually asymptomatic, unfortunately, and it is definitely a challenge to measure and to identify. So let's focus a bit more on this localized versus systemic chronic inflammation. So systemic chronic inflammation is this persistent low-grade immune activation, and sometimes it's also called sterile inflammation, which means that it is triggered without infectious agent or these PAMPs that we mentioned before. So it doesn't have to be caused by a bacteria or a virus. It can also be initiated by DAMPs, so damage-associated molecular patterns, such as excess glucose, cholesterol crystals, and cellular debris. In terms of the inflammatory profile that we'll be seeing in systemic chronic inflammation, it is the elevation of inflammatory cytokines, chemokines, and acute phase proteins. This is all that we will be discussing in the second part of the webinar. And this persistent inflammation can damage tissues and organs. Why is this a huge issue? Is because chronic inflammation definitely leads to an increased risk of physical frailty, and it leads to higher morbidity and mortality rates. So if we ignore pathogens, what are the drivers of systemic chronic inflammation? So we could split them into three separate categories. The primary contributor is definitely age. And we know that inflammation, specifically chronic inflammation, will be increasing with aging. And this is the process called inflammaging. Chronic infections also drive systemic chronic inflammations. Microbiome dysbiosis will drive chronic inflammation. And I think the most important or interesting bit are actually unhealthy behaviors that drive this type of inflammation. So we're looking at smoking, physical inactivity, poor diet, as well as high adiposity and obesity. Social, psychological, and environmental factors also contribute to this. So we're looking at disturbed sleep, social isolation, psychological stress, or exposure to environmental or industrial toxicants. And finally, even early life influences or childhood trauma could impact systemic chronic inflammation in adulthood. And there's actually a lot of studies going on right now that are looking at this. So I wanted to give high adiposity as an example of a driver of systemic chronic inflammation. So specifically, this is related to ectopic and visceral fat that we know have a pro-inflammatory effect. And we know that adipose tissue will secrete adipokines like leptin and adiponectin and produce inflammatory cytokines such as interleukin-6 and TNF-alpha. So that is one mechanism in which it increases, in which visceral fat increases inflammation, but also as fat cells or as adipose cells increase in size and number, some cells which will be located deeper within the tissue will get insufficient blood flow and oxygen, leading to hypoxia and oxidative stress, which further drives inflammation. It is also known that macrophages in ectopic and visceral fat can shift from anti-inflammatory or M2 profile to pro-inflammatory M1 profile, which again will be secreting inflammatory molecules and perpetuating this cycle of inflammation. The worst thing about this whole process is that it doesn't just stay at chronic inflammation, but it also contributes to the development of cardiovascular disease, insulin resistance, and type 2 diabetes. We also mentioned that inflammation is increased in aging, and there's actually been two proposed mechanisms of inflammaging. So the first one is mitochondrial dysfunction that leads to an increase in reactive oxygen species, meaning oxidative stress. And the second mechanism is a decrease in autophagy function, meaning that our cells are not able to clean up dead cells and their contents, which again will lead to an increased inflammatory profile. Chronic inflammation has been added to the 12 hallmarks of aging, and we know that it doesn't stand just by itself, but it's also associated with other hallmarks of aging. So you will notice that on here we have mitochondrial dysfunction that we just mentioned, disabled autophagy, epigenetic alterations, cellular senescence. All of this ties into chronic inflammation. And unfortunately, we know that chronic inflammation is in the background of many different diseases, such as cardiovascular disease, metabolic disease, neurological diseases, autoimmune diseases, definitely, and endocrine imbalance. I wanted to illustrate the example of cardiovascular disease, specifically atherosclerosis, as a mechanism that leads to the development of cardiovascular disease, but is preceded by chronic inflammation. So we know that this is initiated by high blood pressure and other factors that damage the blood vessels, triggering an inflammatory response, which is natural because our body wants to heal this damage. What happens then is that macrophages that are on site, they will uptake oxidized LDL cholesterol and create foam cells. These foam cells will in turn secrete inflammatory molecules that promote the growth of the atherosclerotic plaque, plaque and lead to arterial narrowing. This buildup, of course, can be a huge risk of rupture and subsequent blood clot formation, which can cause heart attacks or stroke. So this inflammation contributes to the progression of atherosclerosis and development of cardiovascular disease. So just to sum up this first part, why do we need to measure chronic inflammation? We need to measure it because we want to identify chronic disease risk early on. We also want to measure it to create personalized preventive health strategies for our patients. And we also would like to measure it and to have a biomarker which will help us monitor and evaluate intervention efficacy. So let's now see what are the currently available biomarkers for inflammation. We split them into 5 different categories. The first one is signaling molecules, and we put these first because they are the first in the inflammatory cascade. Next come the acute phase reactants, such as CRP and high sensitivity CRP, fibrinogen, and ferritin. We will also be looking at CBC elements, such as platelets, white blood cells, and ESR. We'll be discussing some organ-specific markers and novel markers, such as suPAR, DNAm, CRP, and glycans. So we'll start with the signaling molecules, and the first one is interleukin-1. It is actually a group of pro-inflammatory cytokines, primarily interleukin-1 alpha and beta as well. Their role is to initiate and propagate inflammatory responses, to promote fever, and to activate immune cells, just as we saw in the first part of the webinar. And the levels of these interleukins can change rapidly in response to acute stimuli, and we're looking at a half-life of minutes. Usually they're measured in serum or plasma. Sometimes they can be measured from cell culture supernatants, and the testing method is an ELISA. In terms of clinical relevance, right now they're used for diagnosing and monitoring autoimmune diseases, inflammatory disorders, and sepsis. And it is also a therapeutic target for interleukin-1 inhibitors. And there was actually a very famous trial, the Canton trial, which was done in order to study how the monoclonal antibody agonist against interleukin-1b, how it can help in participants who have already suffered from a stroke, to see whether this will lower the risk of future cardiovascular events. So these participants were given the agonist and or actually a monoclonal antibody, against the interleukin-1b, and what we saw is a relative decrease of about 15% in their risk for future cardiovascular events. Unfortunately, when we block the interleukin-1b from its usual function, what was also observed is a higher incidence of sepsis. So from this, what we can see is that the inflammatory cascade is very, very sensitive, and it's very, very highly regulated. So interfering with such crucial parts of it is definitely not a good idea, but measuring in the interleukin-1 for patients that are on IL-1 inhibitors can definitely be helpful, so especially in patients with RA. So let's look at pros and cons of using interleukin-1 as a measure of chronic inflammation. So we know that it has a central role in initiating and sustaining the inflammatory response. We also know that it's an effective target for specific anti-inflammatory therapies, and we know that it is associated with disease severity and progression in chronic conditions. Unfortunately, it is quite challenging to measure because it has multiple forms. So as we just said, it has the alpha and the beta form. Samples also must be processed quickly to avoid degradation, which is sometimes challenging in clinical labs. And measurement assays that are currently available are less standardized and more technically demanding than, say, the CRP assay, and we'll get to that in a second. The next interleukin that we have is interleukin-6. It often works in tandem with interleukin-1, and the main role is to stimulate acute phase protein synthesis, to activate immune cells, and to promote B cell differentiation. It is very highly dynamic, so its levels can fluctuate rapidly in response to acute and chronic inflammatory stimuli. It has longer half-life than interleukin-1, so approximately 1 to 2 hours. The sample that is used for the analysis is also serum and plasma, and it is just like interleukin-1, it is measured by ELISA. Currently, clinically, it's used to assess disease activity in RA, in inflammatory bowel disease, in cardiovascular disease, and in cancers. And it is also a therapeutic target for interleukin-6 inhibitors. The pros are that it reflects acute inflammatory status, and it is targeted by specific anti-inflammatory drugs. But the cons are, again, very, very similar to interleukin-1. It unfortunately is less routinely available, and the assay is quite expensive, and it needs to be processed promptly. The third interleukin, or the third signaling molecule that we'll be looking at, is the TNF-alpha. So it is a very potent pro-inflammatory cytokine involved in systemic inflammation. It induces fever, apoptosis, it inhibits tumorigenesis and viral replication, and it also activates immune cells. Half-life is also measured in minutes, and the testing is done in the same way as with the two previous biomarkers that we discussed. Currently, it is used to diagnose and monitor chronic inflammatory diseases such as RA and Crohn's, insulin resistance, and type 2 diabetes. And unlike the previous two, it is also sometimes used in neurodegenerative disease patients. Of course, it is a therapeutic target for TNF inhibitors used in managing chronic inflammatory conditions. What I will say is that altogether, the pros of these signaling molecules is that they have obviously central roles in initiating and sustaining the acute inflammatory response. However, the cons are that they are quite difficult to measure compared to, again, the very established assays such as the one for CRP. They have multiple forms, and they are also influenced by a diurnal rhythm, which means that it's very, very hard to establish cutoff values. And interleukins, especially, we know that their concentration is the highest in early morning hours, and it coincides with the rhythm of cortisol. So again, depending where in the day you measure these molecules, you will often get a different result, which does not give you a reliable way to assess inflammation in the patient. Moving on to the acute phase reactants, what they are is they are a class of proteins whose concentrations in plasma will either increase or decrease in response to inflammation. And its production is largely triggered by these three cytokines that we just discussed. What happens is that these cytokines will signal to our liver cells to synthesize these molecules because they're needed in our body to neutralize pathogens and remove damaged cells, to facilitate immune cell recruitment and activation, and also help in wound healing and restoring tissue integrity. So you can see all of them here listed, both the acute phase reactants whose concentration increases in inflammation, and ones whose concentration decreases. But we will be focusing on the first group. So I think the most interesting biomarker out of all of these in terms of acute reaction proteins are CRP and HS-CRP, or high sensitivity CRP. They are indeed the very same protein, the very same molecule. The only difference is the assay used to measure them. So the high sensitivity CRP, as you can gather from the name, it can pick up lower concentrations of CRP. What it does in the body is that it binds to dead or dying cells and some types of bacteria as well, and it activates the complement system. It also enhances phagocytosis of pathogens and dead cells, and it is measured by ELISA. So when we look at CRP, the classical assay is that we know that it's elevated in acute and chronic inflammatory states. We know, and it is currently used mostly outside of the space of longevity and prevention as a marker for bacterial infections. And in bacterial infections, it can actually increase up to 1,000 times during severe inflammation. The reference intervals, usually we can say that it is normal when it's below 10 milligrams per liter and elevated when it's above 10 milligrams per liter. When it comes to high sensitivity CRP, it is a more sensitive assay to measure lower levels of CRP, and it is also predictive of cardiovascular disease and stroke in otherwise healthy patients without other risk factors. The reference intervals will vary depending on the country and so on, but usually low risk will be considered for a measurement of below 1 milligram per liter. Average risk is between 1 and 3 milligrams per liter, and high risk above 3 milligrams per liter. Now, there are lots of pros for using CRP in terms of evaluating the inflammatory status of your patients. So the first one is that it's quickly elevated in response to any inflammatory processes going on in the body. It is very well researched and widely accepted in clinical practice. It is useful in predicting CVD and stroke risk in individuals that don't have any other risk factors, and it can very easily be integrated into routine screening protocols for at-risk populations. The cons, unfortunately, are that CRP can and will be elevated in various conditions such as obesity, renal dysfunction, cardiovascular disease, infections, and malignancies. And levels can vary significantly with acute inflammatory events. So when you attempt to use it in terms of assessing the risk, you need to be very, very sure that your patient doesn't have any acute inflammatory events going on. Genetic polymorphisms can also affect baseline CRP levels. So unless you've been following this patient for a while and measuring their CRP levels, you need to be certain again that this increase or decrease is an effect of of the biological process in the background rather than their genetic polymorphisms. Also, when measuring CRP, you need to be aware of any medications that your patient is on, including statins and anti-inflammatory drugs, because they will lower CRP levels independently of the inflammation status of your patient. Factors like smoking, physical activity, and stress will impact CRP levels. So if your patient has been exercising the day prior, it could show up in CRP levels too. And unfortunately, this is a very unspecific marker. So if it is elevated, there's a lot of guesswork that you have to do to understand what is actually causing this inflammation. When we look at other acute phase reactants, we can discuss fibrinogen. So the reference interval is usually between 200 and 400 milligrams per deciliter. Usually it's used to assess coagulation, cardiovascular risk, and also sometimes to monitor inflammation, although that is not very common. High levels will be associated with inflammation, but also with CVD, obesity, and liver disease, and low levels are usually associated with coagulation disorders and malnutrition. So if this is a marker you would like to use to assess chronic inflammation, you need to exclude all of these other factors for it to be useful. So the cons is unfortunately non-specific elevations. It is influenced by lifestyle factors, and it cannot distinguish acute from chronic inflammation. The third acute phase reactant that we'll discuss is ferritin. I will just briefly mention this. The reference interval for men and women is different, as you can see here. Usually it's a marker used to assess iron status. It could be used as an inflammation marker, and high levels will indicate inflammation, but also iron overload or liver disease. And low levels indicate iron deficiency and malnutrition, and usually this is how this biomarker is used rather than for inflammation. So unfortunately, it is not a very good candidate to to assess chronic inflammation. We'll move on to the CBC elements right now. So the first one is erythrocyte sedimentation rate, or ESR. So the assay itself is very, very simple. It is literally the distance that red blood cells in the anticoagulated blood will fall in a vertical tube in an hour. Usually it will rise anywhere from 24 to 48 hours after the start of an inflammatory process. It is an indirect measure of inflammation, and because we're looking at red blood cells and how they interact with each other, fibrinogen is included with fibrinogen activity is associated with ESR. Again, this is a non-specific marker of inflammation because it is also associated with advanced age, with female sex, with anemia, with end-stage renal disease, autoimmunity, and obesity. So if you do see ESR being increased, you need to rule out all of this in order to understand what is actually going on with the patient. Sometimes white blood cell count with a differential can be used in order to understand where in the inflammatory process is your patient. So we can look at lymphocyte subset analysis. And even sometimes I've heard from some doctors that they can use the reference range to indicate outcomes. So looking at whether your patient is at the lower or higher end of the reference range. However, this is not routinely used to assess chronic inflammation, of course. And the last one is the platelet count. Platelets are obviously included in the acute inflammatory response in the later stages when we have cleaned up the wound and when we want to stop the bleeding and we want to start the repair process. So platelet count is usually used to assess hemostasis and thrombosis, and just recently it's also recognized as an important factor in the acute inflammatory response. And it could be useful to assess inflammation in patients. However, more research is needed on that part. But what we do know is that it's involved in regulation and the resolution of the inflammatory response. So might be an interesting one to look at. Next, I will move on to the organ-specific markers, and these ones are particularly relevant for patients with neurodegenerative disease, MS, or stroke. And two of them can be measured, so that's the NFL, or neurofilament light chain, and the GFAP, which is the glial fibrillary acidic protein. And these markers are released upon neuronal damage and can be measured both in cerebrospinal fluid and in plasma, as you can see here. So this inflammation is, again, localized, and it can be used in patients that have either MS or traumatic brain injury or stroke. And the good thing is that it identifies neuronal damage before clinical symptoms manifest, so it can be used kind of to track progression and response to therapies as well. But unfortunately, because we're talking about systemic inflammation, it is not useful in that. If you decide to measure NFLC in cerebrospinal fluid, the lumbar puncture is obviously very uncomfortable for patients, so that's not an ideal test to do, and you definitely wouldn't do it preventatively. And because this is not a routine test, these assays will be more expensive and less widely available compared to traditional inflammatory markers. Very similar for GFAP. So what it is an intermediate filament protein that is expressed primarily by astrocytes in our in our CNS. It maintains the structural framework of astrocytes, and usually it will be upregulated in response to CNS damage or stress, indicating astrocytic activation or injury. It is measured in a very similar way as the NFLC, but again, it is indicative of neuronal or brain inflammation, and it cannot give us enough information about the systemic state of our immune immune system. And now we'll be moving on to the novel markers such as suPAR, DNAm, CRP, and glycans. So this one is very exciting, the DNAm CRP. What it is actually an epigenetic marker that reflects C-reactive protein levels based on DNA methylation patterns. So it almost provides a proxy measure of chronic inflammation beyond typical serum CRP levels. The pros are multiple, again, especially for brain health, because you'll see that DNAm CRP has been shown to be associated with brain health, cognitive decline, and chronic inflammation-related conditions 6 times stronger, with a 6 times stronger correlation compared to serum CRP. And it is also inversely linked with cognitive functions such as memory, processing speed, and visuospatial abilities. There is more research needed to validate this if you compare it to a traditional serum CRP, which for now is affecting acceptance and use. For doctors, it requires understanding of DNA methylation changes, which can be influenced by various genetic and lifestyle factors, which again is something that needs to be taken into consideration when interpreting these tests. And because it's a novel biomarker, there is potentially higher costs and limited availability in standard clinical settings. The second out of these novel biomarkers, the suPAR, or soluble urokinase plasminogen activator receptor, is a very interesting one. And what it is the soluble form of uPAR. It is a receptor which is expressed on our innate immune cells. So what happens is that upon an inflammatory stimulus, uPAR will be cleaved from the cell and released into our blood as suPAR, which we can measure. It can be measured in blood primarily, but also in CSF, in saliva, and urine. And what it does, or what its functions are, is proliferation, migration, adhesion of our cells, but also angiogenesis and the general inflammatory response. It has a very big role in it. Clinically, it seems also very interesting. So it seems to positively correlate with CRP, interleukin-6, and TNF-alpha. And the exciting thing that, unlike all of these other molecules that we discussed, it's actually detectable in healthy individuals. When we look at influencing factors, this is where it gets a little bit disappointing, because you can see that it is approximately 60% genetically determined. Lifestyle also impacts this, so diet, exercise, smoking will impact the concentration of suPAR that we measure, and diseases will also have an impact on suPAR. Currently, it's actually used in triage settings, so it has a high prognostic value for assessing severity and predicting outcomes in acute conditions. And I think this is a great marker to do exactly that. But when it comes to measuring systemic chronic inflammation, there are some limitations. And one of them is that it is elevated in a wide range of diseases, again, from infections, cancers, and other chronic conditions, which reduces its specificity. The other challenge is that the results can vary significantly across different analytical methods, with correlation coefficients often even below 0.3, which complicates standardization. So if you were to use this for a single patient, it would always have to be in the same lab using the same technique, which can be sometimes challenging. It takes approximately 4 weeks to respond to inflammatory stimuli, which doesn't really make it suitable for detecting acute changes or low-grade chronic inflammation. And when it comes to interventional studies, there are actually few of them. But what we see is that existing research actually shows only minimal effects between two measurements with whenever an intervention is introduced. And now we come to glycans, the third of the novel biomarkers, and I believe most of you have already heard our spiel about glycans, and you know what they are, you know what GlycanAge is, but I would love to explain how it ties in with this whole story about acute and chronic inflammation. So let's just look at this diagram for a second. You'll see that we already discussed all of this. So both senescent cells, which will release inflammatory cytokines, necrotic or damaged cells, which will release DNAms, microorganisms, which will release PAMs, and also glycated proteins, which will release the advanced glycation end products. All of this will cause immune dysregulation and will lead to inflammation. Now, these processes actually cause the alteration of the glycosylation machinery, which means that the enzymes that glycosylate our proteins will be functioning differently, which leads to aberrantly glycosylated antibodies, which is a very fancy way of saying that our IgG glycans will be different in inflammation. So just wanted to address this. I mentioned the glycated proteins and the advanced glycation end products. This is very different to glycosylation. So we know that glycation is a random, non-regulated, non-enzymatic process, which happens when we have too much sugar in our bloodstream. It will quite literally damage our proteins, and this is something that we can measure as HbA1c. What we are focusing on with GlycanAge and with glycans is this process of glycosylation, which is the addition of complex sugar molecules onto our proteins, which is a completely normal physiological process that happens to about 60% of all of our proteins. So glycans are very interesting in context of studying chronic inflammation because they have a presence in nearly all processes in our body. So from defining our blood groups to enabling conception to cancer cells using glycans to evade our immune system. And also our immune system actually communicates largely through glycans. And what we do in GlycanAge is that we use antibodies, which, as you know, are part of our adaptive immune system. And we look at glycans attached to the IgGs, which help us understand exactly which inflammatory processes are triggered, and also which glycans are involved in that. This allows us to assess how much chronic inflammation you have, or rather how old your immune system is. And once we have that information, we also know that glycans are a great biomarker because they respond to both lifestyle and pharmacological interventions. You'll see that we've published lots of these different studies, interventional studies, starting from the very basics, diet, weight loss, exercise, different supplements as well, hormone optimization, and we know that glycans respond to all of these. We also know that glycans can predict about 72 different diseases and conditions up to 10 years in advance. And we're actually very lucky because when we say glycans, it is not just one biomarker, it is actually 30 different biomarkers that we're measuring with our test. So because we're able to look at several groups of these glycans, we can have a specific pattern of change that is associated with a specific disease, which allows us to assess what conditions is your patient susceptible to. So to summarize, glycans integrate both the epigenetic, the genetic, and the environmental information. And what it gives you, it's not only the chance to practice precision medicine and to personalize your protocols for your patients, but also to predict what your patient might be susceptible to in the next 10 years and then take proper steps. So to summarize, signaling molecules, acute phase proteins, blood count, organ-specific markers can provide valuable insights, but will come with some limitations such as non-specificity, variability, and technical challenges for some of them. suPAR and DNAm CRP offer advanced inflammatory assessments, but unfortunately are limited by specificity and application scope. And we think that glycans, although we are probably biased, but research shows that it is really so that GlycanAge targets glycosylation patterns that are specific to chronic inflammation. Glycans are definitely less affected by acute inflammatory events. Glycans reflect long-term immune activation and also biological aging, as I mentioned just now. And with glycans, this testing is standardized and very straightforward. So with this, I've spoken for almost an hour. I will thank you for your attention. If you do have any questions, comments after the webinar, please feel free to reach out using this email. And I will be happy to take any questions, so please do ask them now. What I did want to share, one last thing, is that if you would like to see what the GlycanAge test has to offer, please sign up as a partner, as a provider here using this link or this QR code. And also one important thing is that we just started our Black Friday sale today for partners. So whether you are an already existing partner or you would like to try out our test, I would definitely invite you to sign up or to log into your partner account and see what the Black Friday sale is about. So thank you, guys. I will take a sip of water while I'm reading your questions. All right, I can see somebody has their hand raised, so please go ahead. All right, I will start addressing the ones in the webinar chat, and maybe we can then move on to you guys. Okay. The first question is, can you please tell us what you think of True Diagnostics? I don't think I can share my I mean, I can definitely tell you what they do. We know that they measure DNA methylation tests. I think with all of these other tests that are available on the market, it is just about selecting the ones that make most sense for you. We all know that they will show a different way or pathway in which we're aging. So as long as you understand what the test is measuring, as long as you can interpret it for your patients, and it makes sense with the interventions that you're providing them, I think not any, but most biological age tests could be useful for that. However, if you're looking to measure chronic inflammation, as you probably could see from this webinar, I think GlycanAge stands out the most. All right, any other questions, please? Yes, Marco? Marco, did you want to ask a question, please? Okay, I'm not sure I can see you're on mute, but I can see that we have one question in the Q&A. Galactic 3, I think you mean Galactin 3. Do you measure this? This I can see becoming a very interesting biomarker. We unfortunately do not measure it with GlycanAge, but we are able to measure it in our lab. So maybe if you could reach out, we could see what can be done. But yeah, the GlycanAge, unfortunately, we don't measure it in our test. All right, any other questions? If not, I thank you for your attention. Thank you very much for attending the webinar. If you have any questions, feel free to email us either at sophia@glycanage.com or at partners@glycanage.com, and I will see you in the next one. Thank you, guys.